Yeah, very good evening, dear my professional colleagues. First of all, I beg your pardon. There was a technical glitch actually, so our program got delayed by 30 minutes exactly. So let's not waste the time. Let's get into the slides. And at the outset, I thank my professional colleagues and at the same time Mr. Prashant, who is the ABM of this division, for giving me the opportunity to be the speaker of this evening. So, first of all, I would request everybody to uh, type your queries or questions and put it in the chat box right from the beginning so that I can take up the QA session at the end. So with this, so let me introduce myself. I am Dr. Sepuri Krishna Mohan. I am a senior endocrinologist at my own Sepuri Diabetes and Endocrine Center, Kurnool. And today we are going to talk about the use of premix insulins in the Indian context and the flow of contents, the unique characteristics of Indian type 2 diabetes population, and the risk associated with uncontrolled postprandial glucose levels, insulin in the Indian context, guideline recommendations, and a case-based discussion, insulin initiation with the premix insulin, and the final being the take-home message. How are Indian type 2 diabetes patients different from others? So the dietary survey results in an Indian type 2 diabetes population, that is the STAR study. You can see this, they are the India on the left hand side, and you take the northern part or the southern part or the western part or the eastern part or the central part, whatever it may be, irrespective of the reason, the reason wise the macronutrient intake in type 2 diabetes is the major portion is the carbohydrates actually. That is the pathetic thing. That is around you take north, it is 63% of this particular the consumption of carbohydrates, and the total proteins are only 15% and the fats are 22%. So when you take the west, it is 61% and 14% and 25% respectively. You take the east, 65% and 16% and 19% respectively. Take the central part, it is 67% and 14% and 19%. And the south part, southern India, South India, you take it is somewhere around some 64%, 14% and 22% respectively. The carbs and the proteins and the fats. See, if we conclude the data from the present cross-sectional study show that the carbohydrate constitutes 64.1% of the total energy from diet in the type 2 diabetes group, which is higher than the recommended level. So the main culprit is the high carbohydrate intake. And there was a clear non-adherence self-reported to dietary advice in the type 2 diabetes group. So on an average, Indians consume around 64% of carbs in their total diet. So you can see this the relative contribution of the PPG to HbA1c, that is Indians versus Caucasians. See, it is the reversal actually. See, the most of the, like 60% of the HbA1c is contributed by the fasting plasma glucose, whereas most of the case scenarios with the Indians when compared to the Caucasians, we are on the most of the time is spent on the postprandial glucose type, and the relatively the postprandial hyperglycemia is the culprit in the Indian patients versus the Caucasians actually. So the PPG is going to determine the A1C in our population, whereas the fasting should contribute more to the A1C actually. So risk with the uncontrolled postprandial glucose. So you can see this, the uncontrolled postprandial hyperglycemia may lead to wide array of complications. In the center you can see the postprandial hyperglycemia, which leads to the macrovascular disease, the increased carotid intima media thickness, and the decreased myocardial blood flow volume, and the impaired the early diastolic dysfunction, and the increased oxidative stress, and increased inflammatory markers, and increased the risk of retinopathy, and increased risk of pancreatic cancer. This is very important because the duration of the diabetes determines the incidence of the pancreatic cancer. This is of late the latest research finding. So even the risk factor for pancreatic cancer is the 10 or 15 years of duration of type 2 diabetes itself is a risk factor for CA pancreas. So in any category of the fasting glucose, an increase in PPG, that is 2 hour post glucose, resulted in a significant increase in the mortality, that you can see it in the figures, and the postprandial glucose is independent marker of mortality. And more patients achieve HbA1c targets by adhering to PPG targets than the FBC targets. You can clearly see the percent of the patient achieving HbA1c target of around or less than 7%, that is 53 millimoles per mole. We talk about this particular later on, and in patients achieving a fasting plasma glucose of around or below 100 milligram per deciliter, it is 64% it is yes and 36% it is no. When you come to the right hand side, in patients achieving a postprandial glucose target, that is around or less than 140 milligrams per deciliter, that is in the normal persons, that is see the yes is 94% and no is 6%. The inference is the control of fasting hyperglycemia is necessary, but usually insufficient for achieving HbA1c goals of less than or around 7%, as per the recommendations of the American Diabetes Association. And control of postprandial hyperglycemia is essential for achieving the recommended HbA1c goal of around or less than 7%. So what is more important is the control of postprandial glucose, that is 2 hour post glucose determines the A1C, and it determines the multiple complications in the long run. I don't mean to say that you can ignore fasting plasma glucose, and even though it is high, you can pull on with this high fasting fasting plasma glucose. I don't mean it. You need to control both the fasting plasma glucose as well as the postprandial plasma glucose. So there is an entity called, sometimes you rarely find an entity called the fasting hyperglycemia. All the time, whatever you put the basal insulin or the basal plus at the night, or the metformin or glipizide, anything you put, the fasting will be high. That's called, that particular entity is called, it is fasting hyperglycemia. The insulin in the Indian context. See, are we starting the insulin at right time? Absolutely no. The answer is bluntly I am saying we are not initiating the insulin at the right time. So intensive treatment with OADs over a certain period has shown control, but eventually glucose levels continue to rise steadily. So this means there is some amount of pancreatic bankruptcy. So the functioning beta cells. See, so to tell you the basics. See, earlier we used to the think that by the time the doctor says the diagnosis is made, the newly detected type 2 diabetes, once the doctor says you have diabetes, 50% of the beta cells are dead. And now the latest theory is the 50% of the beta cells are dead and 50% are functioning. And now, according to my mentor, Ralph Anthony DiFranco, he postulated that the theory is totally different. That he presented in the New Orleans in the bantering lecture, actually, where I was physically present along with this the team and all. So there he said, by the time you diagnose the type 2 diabetes, 80% of the beta cells are dead, only 20% are functioning, he said. So in India, the insulin therapy is initiated only when the HbA1c levels have deteriorated to around 9%. So even the ADA also, even the American Diabetes Association also says the insulin is the only option when the A1C is around or above 9%. But my experience is you need to initiate insulin much earlier to the stage of the pancreatic bankruptcy, that is where the entire the beta cell functioning mass is totally out, and there is no functioning beta cell at all. It amounts to the scenario of type 1 diabetes. Type 1 diabetes, it's a relentless destruction of the beta cells, progressive loss of beta cells, progressive decline in the functioning beta cells. At the end, you find 0% of functioning beta cells in type 1. So let our type 2 diabetes patients not become type 1 diabetes patients by our negligence, or inertia, what is called the therapeutic inertia, or the clinician's inertia, or the patient's inertia. So the therapeutic inertia for the initiation of insulin therapy still exists. That is absolutely right. And this delay may result in an increased risk of diabetes related complications. See, don't wait for the patient to raise the blood sugars. Even you add 2 OADs, 3 OADs, 4 OADs. They say you at one point of time you should stop adding the OADs, and you should see you don't open the pancreas and see whether the functioning beta cells are there or not. So clinically you need to have an assessment. Even after addition of the third drug, the patient doesn't get back to the glycemic triad. Every time I say that the fasting plasma glucose and the postprandial glucose and the 2-hour postprandial glucose and the HbA1c, when they are not to the target, that is the fasting around 80 to 130 is the goal fixed by the American Diabetes Association, and the postprandial or the random, whatever it may be, 24 hours except the fasting plasma glucose, it should be less than 180 milligram per deciliter, and the HbA1c at any cost should be around or less than 7%. See, don't wait for this. So don't go on adding the third drug, fourth drug. It is a crime actually. See, once you start with the 2 drugs, actually now the funda is totally different. Earlier, 30 years, we used to say like start the metformin unless otherwise it is contraindicated. See, first drug of choice, undoubtedly, so many new drugs have come. The DPP4s have come. The SGLT2 inhibitors have come, even the GLP1 receptor agonists have come. Still, the first drug of choice in type 2 diabetes is always metformin. You please remember that. Unless otherwise it is either contraindicated or not tolerated by the patient. So we used to treat the patient like we used to start with 250 milligram of metformin, and slowly after 50 days or 30 days we used to increase it to 500 milligram. Again 500 milligram in the morning, 500 milligram in the night. Again 1000 milligram in the night and 500 milligram in the night. And again the maximum dose in Indian scenario of metformin, the therapeutic maximal dose is only 2 grams. So whereas in the Caucasians, the Americans or the European people or the Canadians and all, the South Americans, see, it is 2550 milligrams. That is, they have 850 milligram tablets. They take 3 times a day. Because the body mass is, the BMI is high in that particular population, they take 2550 milligram of metformin. But our scenario, Indian scenario, the maximum therapeutic dose, the cutoff is only 2 grams, the 2 in divided doses. Maximum is 1000 milligram in the morning, 1000 milligram in the night. So by the time you escalate it slowly, it takes around 6 months. So the precious time is over. Now the funda is that the treatment of type 2 diabetes must be like hit early, hit hard. Strike early, strike hard. say don't start with one single drug. You start with a combination. Preferably, the best combination would be, ideally, I would suggest is the metformin along with a DPP4 inhibitor as per this particular verified trial, which very fortunately I was one of the principal investigators of that verified trial, which was rolled out in the European Association for the Study of Diabetes, that EASD scientific sessions in Barcelona 2019. What verified trial says is, the inference is that if you use alone metformin, the maximum efficacy of metformin will be lasting for only 2 to 3 years, and after that it doesn't work at all. And the
సార్ ఆ స్లైడ్ అది ఒకటో పేజ్ లోనే ఉంది సార్. నేను ఒకసారి ప్రెజెంట్ చేశాను సార్.
okay, the slides are okay.
సార్ ఒక్కసారి మీరు స్లైడ్ క్లోజ్ చేస్తాను సార్. నేను ప్రెజెంట్ సార్ ఎన్నో స్లైడ్ లో ఉంది సార్?
I cannot say that. See, you can see, are we starting the insulin at right time?
ఓకే సార్. సార్ మీరు ఒక్కసారి స్లైడ్ క్లోజ్ చేయండి సార్. నేను పేస్ట్ చేస్తాను సార్.
Or else we do one thing, Prashant. Shall we hand over the slides to everybody? So that's what the take home message is all the time. The treatment of type 2 diabetes: hit hard, hit early, strike hard. That is, the verified trial says, if you combine the metformin with the vildagliptin, the trial was done actually with vildagliptin. That is the reason it is called verified. So vildagliptin, if you add the initial stage, the time of the diagnosis is made, see, the longevity and the efficacy of the metformin is just doubled. So it works very efficaciously until the at least 5 to 6 years of period. By then you can either add the third drug or the insulin whatsoever you want to add. And on top of it, I would like to repeat once again that the non-pharmacological therapy is the fundamental base for all the lifestyle diseases, starting from diabetes to hypertension to dyslipidemia, the obesity, even the chronic therapy segment like heart attacks and the paralysis, whatever it may be. See, the diet, exercise, and the reduction in the weight, cessation of smoking and cessation of alcohol, if applicable, they remain the fundamentals for all this lifestyle diseases or the chronic therapy segments. So, hence a timely initiation of insulin becomes imperative for reducing the future risk of diabetes related complications. Next slide, please.
Yes, sir.
Yeah. So this slide you can see on the left hand side you can see human insulin formulations, and the right hand side you can see the analog insulin formulations. See, coming to the human insulin formulations, it is short acting and the intermediate and long acting and the premixed. So earlier we had a very long acting also, ultra lenti and all, that is discontinued. So the short acting they absorbed very quickly and last for several hours. It's around the examples they have given, the Insuman, the Rapid and the Act Rapid, different companies actually. So the plasma half life will be 6 to 8 hours, and the intermediate and the long acting, the more slowly absorbed, because that is called NPH. We add a zinc to that, the neutral protamine hekdon, that's what NPH. It's a more slowly absorbed, lasts for up to 24 hours. The example is Insulatard. Actually, Insulatard doesn't last for 24 hours actually. It lasts only for 12 to 14 hours actually. And I'm sorry to say that human insulin formulations, we don't find any insulin acting for 24 hours actually. So the premixed, the mixture of short and the long acting, the biphasic premixed human insulins. Example that is the human mixture or the Aminsulin 25 or Aminsulin 50. And coming to the analog insulin formulations, it is rapid acting. So absorbed very rapidly, lasts only for few hours, that is 4 to 6 hours only. So that the aim is to control postprandial glucose. Example, the glulysin, that is Apidra, that is Sanofi. The Aspart, that is Novorapid, that is from Novo Nordisk. And the Lispro was the first rapid acting analog actually. Lispro is from, that is the brand name is Humalog, that is from the Eli Lilly. The long acting more slowly absorbed to provide a low level of insulin throughout the day and night. Example, Glorgin U100, that is from the brand name is Lantus, that is from Sanofi. Now the Detimer, that is the Levimir from Novo Nordisk. And ultra very long acting, very slowly absorbed and designed to act for more than 24 hours. There are only like two, that is Glorgin U300, that is Tuzio from the Sanofi, and the Degludec, that is Tresiba, the brand name from Novo Nordisk. And the premixed is the analogs, mixture of rapid and intermediate acting or the long acting insulin, that is the Novomix 30 is the one from the Novo Nordisk, that is Aspart mix actually, the Aspart and the Aspart protamine. Likewise, the Humalog mix was the first of its kind to enter into the market from Eli Lilly, that is the Lispro mix, that is Lispro and Lispro protamine actually, protaminated Lispro. And the Idacasp, but Idacasp doesn't fall into this particular category because we call that Rhizodec, that is the combination of insulin Degludec and insulin Aspart as basal plus actually. So next slide please. So coming to the guideline recommendations. And recommendations from global and Indian guidelines for insulin initiation. The American Diabetes Association and the American Association for the Clinical Endocrinologists and the International Diabetes Federation and the Canadian Diabetes Association, they recommend how to start the insulin, how to initiate the insulin. Say there are so many types of insulins you can initiate. So as these 4 international bodies, they say, so start with basal insulin, that is the best, what they say. So the advantage is that it is once a time the insulin, basal insulin. Usually we give it at the night 10 o'clock or the evening 5 o'clock is the second best ideal time. But the disadvantage is it can control effectively the fasting plasma glucose, but it cannot control the postprandial glucose. And the second is NICE, that is National Institute for Health and Care Excellence, that says, that is UK. This is NICE, NICE. So it says either basal or premixed insulin. This is good actually. And coming to the last one on the right side, it is the RSSDI, that is the Research Society for the Study of Diabetes in India, that is and the EADS, that is East African Diabetes Study Group. That is nowadays the more research is being done in this particular EADS. We underestimate these the East African people actually. So the East African people, they are doing lot of research, lot of the innovations, and they are making lot of international guidelines, because the very less knowledge the all over the world the people have about EADSG. It's actually that started in 2011 actually. So there are some 20 to 22 countries, the most backward countries of this particular the African continent. That is, they're starting from, like, I'll just give you some examples. The countries where this particular the EADSG arise from. So the backward countries like Ethiopia, the Kenya, the Somalia, and the Rwanda, the Mauritius and the Seychelles, and the Madagascar, and the Uganda, and the Burundi, and the Zambia, Tanzania, and Zimbabwe, and Sudan and South Sudan, and Mayotte, Malawi, the Reunion, and the Mozambique. These are the countries which have formed a separate study group for diabetes, which is called EADSG. And the Diabetes Australia, that is, and the clinical practice guidelines from Malaysia, they said either you can start with a basal insulin or a premix insulin or insulin co-formulations. See, in this regard, I would request everybody, because if you become a life member of this particular international life member, you want to become this the East African diabetes study group. It is very cheap. You can become just by paying $200. You can become an international life member of this particular the group actually, and you can access the articles, and you can download the articles. You can go through the slides. They are doing. See, we are literally ashamed as Indians to compare with this particular the so-called very backward the countries in the world. So they are doing lot of research. They are the very innovations, and they are preparing the international guidelines actually. So we must be proud of this EADSG. Next slide, please. So these are the different recommendations for insulin initiation. So starting from the ADA guidelines, that is 2023. So add basal insulin analogs or NPH insulin at bedtime. That is what I said, 10 o'clock ideally. 10 units are 0.1 to 0.2 units per kilogram per of body weight in a day. In an individual or basal insulin in whom additional prandial coverage is desired, the regimen can be converted to 2 doses of a premixed insulin. And coming to again the ADA or EASD consensus, joint consensus report 2022 says start the using basal insulin 10 units at bedtime, 10 p.m., 10 units 10 p.m. You remember that, or 0.1 to 0.2 units of kilogram per day at bedtime, or more flexibility with the timing for the longer acting analogs. As far as the Canadian Diabetes Association 2018, that says start using basal insulin and titrate to achieve fasting target glucose. See, this there is a fundamental thing in this particular what Canadian Diabetes group says is, you always remember 3 F's. Fix the fasting first, then only you can catch up the postprandial. See, that is scientifically proven also. Unless you fix up this particular fasting plasma glucose first, you cannot catch up the postprandial glucose. Maybe this Canadian Diabetes Association strongly believes in 3 F's actually. Fix the fasting first, start using basal insulin and titrate to achieve fasting plasma glucose, and continue metformin unless contraindicated. I said either contraindicated or not tolerated by the patient, don't take off. See, all these guidelines, what they say is it is not only insulin. See, along with the existing drugs, you need to add either the basal insulin or the basal plus or the basal bolus or the biphasic premixed must be used along with this, except the basal bolus actually. See, when we use the basal bolus, there is no role of the OAD. So coming to the right hand side, the IDF guidelines 2018, they say basal insulin should be preferred and it can be temporary. And the AAS, that is the American Association for the Clinical Endocrinologist 2022 says the insulin therapy may be initiated as a basal or a basal bolus or prandial or premixed insulin, although for the most persons with the type 2 diabetes, starting with a basal insulin analog added to the existing anti-hyperglycemic regime is preferred actually. Next slide please. So this is the nice clinical practice guidelines from UK, that is the updated version is 2022. Start insulin therapy for adults with type 2 diabetes from a choice of the following insulin types and regimes, and offer the neutral protein Hegdan, that is NPH insulin injected once or twice daily according to the need, and consider starting both the NPH and short acting insulin, particularly if the person's HbA1c is the 9% of A1C. So we calculate in terms of milligrams per deciliter, whereas the rest of the world they talk about in terms of millimoles per liter, and administer either separately as a premixed biphasic human insulin preparation. Consider as an alternative to NPH insulin using insulin detumer or insulin glargine if the person needs help from a carer or the healthcare professional to inject insulin, and use of insulin detumer or the insulin glargine would reduce the frequency of injections from twice to once daily, and the person's lifestyle is restricted to recurrent symptomatic hypoglycemic episodes, or the person would otherwise need twice daily NPH insulin injections in combination with the oral glucose lowering drugs. And as far as the biphasic premixed is concerned, today's topic, consider it NICE guidelines 2022, they say that they consider premixed biphasic preparations that include short-acting insulin analogs rather than the premixed biphasic preparations that include a short-acting human insulin preparation. If the person prefers to injecting the insulin immediately before a meal, or the hypoglycemia is a problem, or the blood glucose levels rise markedly after meals. The only difference between, I would like to go to fundamentals again. The basic difference between the human insulins and the analog insulins is, the first thing is you don't need to wait for half an hour as for the, like you wait for the human insulins. You don't need to wait for half an hour. You can just give it 5 minutes prior to the meal, or just a minute prior to meal. You take the insulin and you can have the food. Even in between, you forget about the insulin. In between in the meal, you remember that you have missed your insulin. Then you can stop, you can inject. Even after that also you remember, you can inject. That even works. That is the difference, basic difference between the analogs and the human insulins. Because all the time the human insulins are present in the form of hexamer. The insulin is present in the form of hexamer as long as it is in the bottle or the cartridge or the pen fill or the Usanthro pen. So once it is injected into the abdominal wall, then it dissociates into a dimer, and a dimer becomes the monomer, and monomeric insulin is the active principle of the insulin. So for this biodegradation, once it is injected into the body, takes around 30 minutes time. Minimum time is 30 minutes. There is a reason whenever you take the human insulins, you just have to wait for 30 minutes before you take your meal. Whereas the analogs, they are in the direct form. That is, the monomeric form is the active form of the insulin actually. So it is present in the monomeric. The moment you inject, they start working. So that is the difference between this. And second thing is, the incidence of hypoglycemia is very much low with the analogs, and it is much higher when compared to the human insulins. And the third one is, the weight, the gain is very much low with this insulin analogs, whereas you find the weight reduction is more with the human insulins. That is the difference actually. And that too, when the blood sugars are markedly high, the analogs work very well when compared to the human insulins. I don't say that every patient should be put on analogs and you stop writing human insulins and go for analogs. It depends on the economical condition of the patient and the requirement and the work style actually. The multiple factors are involved in this. So the business executive is very busy. He is very busy with these meetings and all round the clock. So analogs, if the affordability is not a problem, always I tell you affordability, affordability, affordability. The economical factors are not there. So the patient is able to afford to go for analogs. The money is not a problem at all. Go for analogs. Where the money is the biggest barrier, in our country, the money is the biggest barrier, and lot of socio-economical, cultural variations are there. So the most of the times, even for the last more than 3 decades of my clinical experience, so 80% of my patients are still on the human insulins, either the biphasic premix insulin or the NPH, whatever it may be. But the only of the affordable segment 20% who have got the no problem with the money, or they got the reimbursement system, like an officer comes from the State Bank of India, or the software people, they come, they get all the things reimbursed, the consultation and the investigations and the medicines, so they can afford to go for that because they are not paying from their pocket. So these are the some advantages and disadvantages of human insulin and the analog insulins. Next slide, please. So these are the RSSDI, the 2022 indications, actually the recommendations. Initiate with once weekly basal insulin, once daily premixed co-formulation insulin, or twice daily premixed insulin, either alone or in combination with the other OADs, based upon the patient's age, clinical features, glucose profile, risk of the hypoglycemia, and the patient's preference. Basal insulin may also be initiated in combination with the GLP-1 analogs, actually. Coming to the next slide. See, on the right hand, left hand side, you can find the Australian clinical practice guidelines, that is the RACGP, nothing but Royal Australian College of General Practitioners. The guidelines say that select 1 or 2 insulin schedules, the basal insulin, the Glargine U100 or Glargine U300 once daily, irrespective of meals. And the second thing is co-formulated insulin. That's what I said, co-formulation. The only one co-formulation in the world is the Rhizodec, that is insulin degludec and aspartate, which is called the co-formulation, or the basal plus insulin. That is the only one in the world, one of its kind. Or the premixed biphasic insulin, that is Lispro and the protominated Lispro, or the aspart or the protominated aspart, once daily before the largest carbohydrate containing meal of the day. So coming to the again our the EADSG, that's what I had elaborated about, that East African Diabetes Study Group Clinical Practice Guidelines 2018, they say that the preferred method of insulin initiation is to begin by adding a long-acting basal insulin, or that is once daily premixed co-formulation insulin, or twice daily premixed insulin alone, or in combination with glucagon-like peptide GLP-1 receptor agonist, or in the combination with other oral anti-diabetic drugs. Next slide, please. So the factors indicating the premix as choice of insulin, and why we should choose the premix insulin. So these are the several factors, the glycemic factors and the psychosocial factors and the phase of the life and the Indian realities. These are the 4 components divided into this particular, the choosing the premix insulin. And coming to the glycemic factors, if the postprandial increment is more than 54 milligrams per deciliter, that is the fasting plasma glucose bar the HbA1c ratio is less than 20, the difference between the bedtime and the morning blood glucose value is more than 55 milligrams per deciliter. These are the factors where you need to go for the premix insulin. So the psychosocial factors, if the patient has limited literacy and a simple and easy to understand regimen is needed for insulin initiation, if simple and convenient options are needed for the future intensification, you need to choose a premix insulin. And the phase of life, adults at early or the progressed stage of disease and elderly patients in need of simple therapy, that is an indication for choosing the premix insulin. And coming to the Indian realities, if within limited resources, the simple and the easy to explain insulin therapy is needed for initiation and intensification. And if the patient is on high carbohydrate diet, inevitably we are on high carbohydrate diet. I said on an average it is around 60 to 70% of our total diet is coming from the carbohydrates. Let it be simple carbohydrates or complex carbohydrates, that's a different entity. So all the time, say we need to either reduce this particular the carbohydrate diet, and what I suggest is, as per the evidence-based medicine says, 40% of our food should be from the carbohydrates, that too complex carbohydrates, more of complex carbohydrates, and 30% proteins and 30% fats. This is the ideal one. 40 30 30 is the ideal one. But as Indians, I think we cannot either leave apart the idlis or the dosa in this South Indian context, and the rotis in the wheat based rotis in the North Indian context. So most of the staple diet from our either any part of India, it is the carbohydrates. So in that case, the option would be very simple and convenient. Option is either for initiation or intensification is only this particular the premix insulin. So premix insulin such as Lyspro Premix 25, that is Humalog Mix 25, and provide control both fasting plasma glucose and the postprandial plasma glucose, along with the convenience of initiation, titration and intensification. And the patient selection and the premixed insulin. And the considerations at initiation, either the premix or the basal insulins. See what is the postprandial increment. There are certain questions you need to like. See what is the postprandial increment. If it is more than 54 milligram per deciliter, so go for premix. If it is less than 18 milligram per deciliter, so go for basal insulin. That as simple as that. If the postprandial increment is more than 54, go for premix. If the postprandial increment is less than 18 milligram per deciliter, go for basal. And is the patient likely to manage basal bolus therapy when intensification is needed? If the answer is no, you go for the basal insulin. And if the answer is yes, go for the premix. Is there a large carbohydrate intake at 1 or 2 meals? If it is yes, you go for the premix. If it is no, you go for the basal. The patient's lifestyle is predictable, that is eating pattern and the working hours. See, it's very difficult to decide the type of insulin what we use. See, nowadays the call centers have come, the software people employees. Earlier it was only daytime duties in all over the world, before I think 30-40 years ago, and now it is the nighttime duties have started. We are going against the nature. Always going against nature is not that easy to cope with. See, nighttime call centers, 12 hours nighttime, and they sleep in the daytime. And the time, there won't be any shift also. They are permanent employees working for the daytime, no problem. The night time is the biggest the hassle actually. So if it is yes, go for the premix, which can maintain the any pattern of this thing, the work style or the working hours or the eating patterns. If it is no, like don't go for the basal, go for premixed. And these are premixed versus basal bolus, the meta-analysis results. And the factors that affect the choice of the intensified insulin regime is the number of injections, which are certainly fewer, and with premix insulin, usually it is twice a day. Premix all the time it is twice a day. So self-monitoring of blood glucose, that is SMBG, which will less frequent with premix insulin, and the patient's ability to inject insulin, which will be convenient in case of premix insulin. These are the the factors favoring premix insulins. And the analysis of 13 RCTs lasting for the last 16 to 60 weeks they concluded the non-significant 0.09% difference in the HbA1c level achieved by the two regimes, and the premix and the basal bolus showed no significant difference in the rate of hypoglycemia, weight changes, and the daily insulin dose despite the greater complexity and the number of injections associated with basal bolus insulin. So the difference between premixed, biphasic premixed insulins, whether it is human or whether it is analogs, or the basal bolus is, we give two injections in the premixed biphasic, either human or analog insulins, whereas we need to go for at least 4 to 5 injections, 3 prandial insulins, 1 or 2 basal insulins, in this case the basal bolus. So the patient has to take a lot of injections. So the number of injections is going up, the tolerance of the patient goes down actually. Next slide please. So this is the slide showing the insulin therapy in type 2 diabetes, which regime is best for intensification. It is always I said the high mix insulin, that is Humalog mix 50 holds good for this. Okay, and let us come to the case studies. Okay, next slide please. Case study. See, this is case number 1, the role of premix insulin in patients with uncontrolled on-VOADs. So next slide please. So the T2DM patient uncontrolled on VOADs, multiple VOADs. It's a female patient, 52 years of age, and the history is, the medical history is, the patient is been suffering from type 2 diabetes for the last 12 years and she is taking the treatment. A1C was 9.3 at last visit 6 months ago. So that is the right indication for initiation of insulin. Patient weight has been stable since last visit, and the physical exam shows the weight is 74 kilograms and the body mass index is 26 kilograms per meter square. As per the Indian guidelines, she doesn't belong to overweight, but she belongs to obesity. And blood pressure is 130/90 millimeters of mercury. That is, so she's got the 10 points excess diastolic blood pressure. So she is hypertensive. Feet normal, eyes normal. And the lab results, the blood glucose is, the A1C is 9.3%, and the fasting plasma glucose is 146 milligram per deciliter, and the 2-hour PPC is around 255 milligram per deciliter. Kidney function creatinine is 1.1%, 1.1 milligram per deciliter, and all the time you try to calculate the EGFR. Decisive, they see, don't depend on the serum creatinine, which is a very decisive parameter. All the time they calculate the EGFR, and the EGFR here is 74 ml per minute. That is very much okay, normal. And the urinary albumin creatine ratio is 70 milligrams. That is, the patient is in the stage 1 nephropathy, actually, not nephropathy, the diabetic kidney disease actually. So now the microalbumin, the term microalbumin is being replaced by urinary albumin creatinine ratio by the American Diabetes Association. Coming to the lipids, cholesterol, total cholesterol is 250 milligram per deciliter, and LDL is 165, terribly bad. HDL is 35, and triglycerides it is 250 milligram per deciliter. It is on the higher side. So LFT, the AST is normal and the ALT is normal. And the clinical challenge, the reason for visit is blood sugar is not under control. The medication she is on is sitagliptin 100 milligram OD, glimepiride 4 milligram a day, and metformin 2000 milligram a day, atorvastatin 20 milligram the HS, and the losartan 50 milligram BID, and chlorthalidone 25 milligram HS. And the family history is coronary artery disease in father at the age of 56 years. And the social history is she is a homemaker and a highly social and dietary pattern, predictable diet with heavy breakfast and dinner. And the complaint the compliant with medications, and hypertension, history of urinary tract infection for the last 6 months, not adhering to lifestyle changes. So this is the clinical challenges what our case one, the female has. And now let us, the next slide shows the evidence actually. So the Lyspro Premix 25 BID plus metformin versus insulin glargine HS plus metformin patients new to insulin, that is insulin naive patients. See on the left hand side we can see the glargine HS plus metformin, and you can compare the bar diagrams, and it is compared with the Lyspro Premix 25 BID plus metformin, and on the right hand side you can see the bar diagrams which show that HbA1c value is of around or less than 7%, fasting plasma glucose around or less than 7%, or this particular and the conclusion, the better reduction of A1C and attaining target goals with Lyspro 25 premix is seen when compared to the insulin glargine. Because insulin glargine is a basal insulin, I told you basal insulin can only control the fasting plasma glucose. That is, that can fix the fasting plasma glucose, but that cannot fix the postprandial. Whereas the Lyspro premix, that is the Lyspro plus the protominated Lyspro, which becomes the analog biphasic premix insulin, is proven to be much better when compared to the basal insulin, especially in our Indian scenario. And next slide, the overall hypoglycemia rate was low in both the groups. The nocturnal hypoglycemia was similar in both the groups. And back to the case. Started on Lyspro Premix 25 and 10 units before breakfast. That is the 10 we started this premix insulin only one time a day, that is with the breakfast, because we had seen in the earlier slide that she takes a heavy breakfast and heavy dinner. See, dose was titrated at weekly intervals. After 4 weeks, second dose of Lyspro Premix 25 was introduced, 10 units before dinner, and receiving 18 units before breakfast. So we intensified the morning dose by 18 units, and we initiated the 10 units of night dose. And further 4 weeks later, she stabilized at Lyspro Premix 25, that is 22 units before breakfast and 16 units before dinner, and glimepiride was discontinued. See, my humble submission to everybody is, whenever you start an insulin, whatever it may be, you please either reduce the dose of glimepiride or the sulfonylurea modern. See, if you they divide the sulfonylureas, like there are two classifications, the first generation, second generation, and the third generation. The older sulfonylureas and the newer sulfonylureas. The newer sulfonylureas, they are glimepiride and the glycoside, that is extended or modified release XR, and the older ones are the glibenclamide and the glipizide. So nowadays we are totally discouraging, especially the older generation, especially after the age of 60, because of the severe hypoglycemia, because they are very potent when compared to the modern sulfonylureas, the glimepiride or glycoside. Glibenclamide is the most potent and followed by the glipizide. So though they are potent, whenever the drug is very potent, automatically the incidence of hypoglycemia will be more, especially the nocturnal hypoglycemia or the L3 hypoglycemia. Again, hypoglycemia is divided into level 1, level 2, level 3. Level 3 is the serious one, where the patient has to be hospitalized. So we don't want to invite all these complications. And the weight gain is also more when the drug is very potent. So when compared to glibenclamide glipizide, the weight gain is there with glimepiride and the glycoside inevitably. But when compared to that, the incidence of hypoglycemia, the incidence of weight gain is little bit better with the modern sulfonylureas or the third generation sulfonylureas. And further 4 weeks after, the patient was stabilized with the 22 units of the Lyspro Premix before breakfast and 16 units before dinner. Glimepiride was discontinued at 3 months. Blood sugar, the control A1C was around 7.5%, which is much better actually. But coming to the case 2, next slide please. And the role of premix insulins in patients requiring insulin intensification. So next slide, the intensifying insulin therapy a step further actually. It's a case of the 60-year-old male, and the duration of diabetes is 15 years and weighing around 80 kilos, whose BMI is around 26 kilograms per meter square. Again, the current medication is metformin 500 mg BD, vildagliptin 50 mg BD, and glimepiride 2 mg BD, and Lyspro mix 25. It is 24 units before breakfast and 16 units before dinner, and the A1C is 9.2. In spite of taking all the drugs, so she is on 3 oral drugs actually, on metformin, and though not the full dose, but she is on 1000 milligram. The patient is on, the male, he is on 1000 milligram of metformin a day, and 100 milligram of vildagliptin a day, and 4 milligram of glimepiride a day. 3 OADs plus the Humalog mix, that is the Lyspro mix 25, 24 units in the morning, 16 units in the night. Still the A1C is so high, the patient needs badly the intensification. So the right hand side you can see the 7-point self monitoring of blood glucose and the blood glucose values and the postprandial excursions. The 7-point is nothing but the first thing is the before breakfast and after 2 hours of the breakfast, and before lunch and 2 hours after the lunch, and before dinner and 2 hours after the dinner, and at 3 a.m. in the morning. This is called the 7-point formula of monitoring the self-monitoring blood glucose. So when you do that, the postprandial excursion was 113 and after the breakfast, and 30 after lunch, and after dinner it was 72. So that means the premix insulin, the analog what what the patient is taking is definitely not sufficient. We need to intensify, that is. And the next slide evidence, and next slide shows the bar diagram shows that the similar A1C reductions and similar the proportion of patients achieving glycemic targets with Lyspro Premix 50 compared to the BBT actually, and you can very clearly see the similar glycemic control without increase of severe hypoglycemia with lesser number of pricks actually. And back to case 2, the patient was switched to Lyspro Premix 50. From 25 we have made it 50, that is Lyspro 50, protominated Lyspro 50. So once daily before breakfast and Lyspro Premix 25 before dinner. So 50 in the morning, 25 in the night. And Lyspro 50 premix dose was 20 units before breakfast, and the 25 was 16 units before dinner. Dose was titrated every week. After 6 weeks, the patient got stabilized on Lyspro Premix 50, that is 24 units in the morning with the breakfast, and Lyspro Premix 25, that is 20 units before dinner. At the end of 3rd month, the A1C was 7.4, which is reasonably good. And we have come to the last slide, please. The summary or the take-home message. The significant contribution from PPG even at a higher HbA1c in Indian population as compared to Caucasians. And the premix insulins are simple to start with single injection and effective HbA1c control targeting both PPG and FPG. And patients uncontrolled on 2 or more OADs with disciplined lifestyle can be initiated on premix insulin, and dose can be titrated on a weekly basis. Premix insulins provide the convenience and simplicity at initiation and titration and intensification. Premix insulin provides both convenience and efficacy to the patient and aids in achieving the patient's glycemic target. with this we come to an end, and thank you so much for your patient listening in spite of the initial technical glitches. I am sorry that the problems with the technical problems, I was not able to give you the slides at all. But okay, if you have, I've told you in the beginning itself, any doubts, please put it in the chat box. I'll wait for 5 to 10 minutes to take up your question and answer session. So that meanwhile, if you have not typed your queries or the questions, so you can type and put it in the chat box so that I can take it after 5 minutes or 10 minutes. Prashant, are there any questions already?
Yes, sir. Is there, sir?
If the questions are there, you can just I think we can continue that.